Hi guys, we'll just give it a couple of minutes for any last minute people to join and then we'll make a start. Okay, we'll make a start and hopefully a couple more people will come in the next few minutes. So evening everyone, thanks for joining us again. So as I'm sure some of you know, this is our Road to Final series. We're a good 4 or 5 sessions in now. And today I've got Ross and Jed who are going to go through cardiology. As you guys may or may not know, this is a long-running series that we at Medtech Teaching are running. Every Thursday, around an hour and a half, some SBA style questions with explanations, which are looking at covering the new UK MLA syllabus. So our next session would be the same time, 7 p.m. next Thursday, and we'd be doing MSK and orthopedics. Just a couple of things. If you have any questions, please feel free to pop them in the chat. I'll keep an eye on. Of course, feedback and everything will be at the end. So we'll have certificates for you guys. And all we ask is that you do Ross and Jed a favour, who've very kindly given up their time to teach you guys today. Just give them some feedback. It helps them out a lot. And I'm sure you guys will be in the same position in a year's time, hopefully. So I'll hand over to Ross and Jed. Thanks, guys.
Thanks for the intro. So, hi, my name's Ross, and this is my colleague Jed. So we both started our first rotation in cardiology together in Brighton. So we thought we'd be good to maybe help lead a session on this. So the format of the session, so it's all MCQ based. We're not going to delve. We'll go into detail as to why we've chosen each option, but we won't cover the entire topic holistically. This is just exam content focus, what's going to be high yield. Some of the questions, they might be a little bit harsh, but it's just to get you to think a wee bit and stop you falling into the common pitfalls. So here's some of the topics we're going to cover today. Let you have a quick reread. But otherwise, I don't want to spoil some of the answers, so we'll get stuck into it. So this is the first question. So a 73-year-old woman arrives in A&E having experienced 3 hours of sudden onset severe crushing central chest pain, radiating to her left shoulder and jaw. She has a history of type 2 diabetes, hypertension, and moderate aortic stenosis. She takes metformin, amlodipine with no known drug allergies. Her observations in ECG are as follows. She's saturating 96% on room air. Her blood pressure is 142/76, and her heart rate is 65 beats per minute. What is your initial management prior to senior review? I'll rely on Jed to put the poll up, so just give it a sec. So I'll give you guys a minute to answer. Okay. So we've got 2 responses. Okay, we're getting a bit more now. I'll just give you guys another few seconds and then we'll go into it. So I can see some of the responses. So you can see a couple of you have gone for A. There's a good spread. Some of you have gone for C, D, and then it looks like 3 or 4 of you have gone for E. So the answer is actually C. So we'll go into a bit of why. There are a couple of trip ups there. So I hope you're able to gauge this lady is suffering from an NSTEMI. So from the question, you can see she's having a typical presentation and she's got some risk factors. She's got the sudden onset severe central chest pain. It's radiating to her left side. She's got the risk factors of age, increased age, diabetes, hypertension, and valve disease. And then hopefully the keen-eyed of you would have seen on the ECG, she's got some ischemic changes. So she's got some ST depression in leads 1 to 3. It's in AVF. There's a bit in V4, V3, V5, and V6, but this is most likely an inferior lateral NSTEMI. So let's go into each option as to why it wasn't that. So for those of you who put A, so A is the only option with oxygen. So this lady's saturating 96% on room air, so she doesn't have an oxygen requirement. Studies show if you unnecessarily ventilate people, there's actually a worse outcome in an ACS point of view. So then why wasn't it B? So can anyone write in the chat, why did we, because the only difference there is the GTN, why have we not given this lady a GTN? Is anyone able to say in the chat? Any takers? GTN is for angina, yeah. But why haven't we given GTN to this lady? There's one reason. Okay, I'm gonna put you out your misery. So this lady's got aortic stenosis. So nitrates are contraindicated in aortic stenosis. So for her, so she's got moderate aortic stenosis. These patients are dependent on their preload. So preload is the volume of blood that fills up during diastole. Nitrates cause vasodilation and hence hypertension, and therefore reduce the preload. But because these patients have got a stenotic valve, the aortic stenosis, they can't increase their stroke volume in order to cope with the drop in blood pressure. So hence it tanks their blood pressure. So yeah, avoid GTNs in those with aortic stenosis. In terms of antiplatelets, so why haven't we gone for D or E? So as an F1, and this is the initial management prior to senior review, as an F1, I wouldn't make any decisions regarding a secondary outplatelet. In any acute coronary syndrome, you would need a really good reason to not start aspirin, such as they have a very, very high bleeding risk, but this lady doesn't look like she has one. So yeah, in terms of the second antiplatelet, we don't yet know what the definitive management plan is. She hasn't been seen by a senior. So we don't know if she's going to be medically managed. We don't know if she's going for PCI. We don't know if she's going to have fibrinolysis. Adding a second antiplatelet will increase her bleeding risk and potentially influence the definitive management plan. So as a port of call, I would hold off starting a second antiplatelet. I hope that makes sense. So let's go a bit more detail to ACS. So acute coronary syndrome refers to a spectrum of conditions. So really useful to think of it as a spectrum where the coronary arteries are becoming narrowed. So this image on the left, I think, helps to display this, the differing pathophysiology between stable anginas, unstable, and DMIs. So with a stable angina, you've got a stable atherosclerotic plaque that builds up on the inside of the arteries gradually over time. And then in unstable angina, there's some disruption or break in that plaque causing platelet aggregation, but the artery is still patent. There's no cell death. There's no infarction. There's still ischemia being reduced oxygenation to the myocardium. So that's causing pain, but there's no infarction. Then we get to an end STEMI where there's a significant plaque rupture or a thrombus, and that's now causing non-sustainable occlusion. So there's still some flow in an end STEMI, but there's not enough collateral supply to supply the myocardium, and the patient's resulting in myocardial infarction. So there is cell death. That's why they're going to get a troponin rise. And then finally, with STEMI, there's a total blockage of that vessel, which is going to result in critical ischemia and is going to warrant urgent investigation. So the three diagnostic tools that you're going to use to narrow down on ACS. So history. I know that sounds obvious. We've sent patients for an angiogram before to PCI just based off of the history alone, even when their troponin and ECG was negative. So history is really important. Troponin's one of those tests we're encouraged to think of not as diagnostic nowadays. It's really, really, really sensitive. So as in it'll pick up nearly everyone in ACS, but it has a poor specificity. So it'll have a lot of negative positives, if I said that the right way around. It'll pick up a lot of individuals not having a STEMI or an end STEMI. So it can be raising chronic kidney disease, it can be raising sepsis and pneumonias, it can be raising myocarditis, even a PE. And then finally in ECG. ECGs, again, be careful because you won't always get ischemic changes initially, especially if they present really early. And then finally, the image on the right is from the European Society of Cardiology. Again, this is just helping to differentiate between the difference on the ACS spectrum, the different investigation results. Most important takeaway here being the difference between an end STEMI and unstable angina. If you have a trop raise, that could be an end STEMI or a STEMI. If you don't have a trop raise, it's not that. So in an unstable angina, you're not going to have a trop rise, right? So next, this is a sort of summarized version of the NICE ACS guidelines. So the top part, this is the initial management for all ACS, and I want you to keep it really simple. And especially as an F1, this is all you're going to have to do. Just think MONA, not MONAT, not MONAC, just think MONA. So it's not in any particular order, but it's just to encourage you to think about this sort of stuff. So morphine, obviously to manage their pain, you can think about oxycodone as well. And metoclopramide, again, they're going to be feeling sick potentially because of the ACS. Be careful with metoclopramide if they're at risk of arrhythmia. So you might want to consider cyclizine instead. Oxygen, only if they have an oxygen requirement. So don't let that trip you up. Nitrites, as we said, avoiding those with AS. Nitrites can be really good though. If the sublingual GTN is not working, what you can do as well is you can set up an infusion of GTN, and that's actually really effective. And then aspirin, load them on a loading dose of 300 milligrams. You would need a good reason as to why not to start it. Once you've done that, then you can think about your more definitive management plan, depending where on that spectrum you think the patient is. So for an unstable angina on the left here, so we would still risk stratify them and consider the benefit of sending them for coronary intervention PCI. So patients with unstable angina, if they've got a lot of risk factors, if you think they have a high clot burden, you can still send them for PCI. But generally, if they're low risk, we'll opt for conservative medical management. So this will involve starting anti-anginals. There's a stepwise sort of approach I've included in the top box up there. You would start with, for anti-anginals, you would start with a calcium channel blocker or a beta blocker. The next step is you'd up titrate that dose. the third step, if they're still symptomatic, you would add in the other drug you didn't start. Just be careful when you do. It needs to be a non-rate limiting calcium channel blocker. You can't have a rate limiting and a beta blocker, because then you get heart block. So a non-rate limiting would be something like amlodipine or nifedipine. And then finally, if you're getting to the stage where you're having to think about adding a third drug, add the third drug. So that could be isosorbide mononitrate, a longer acting nitrate, or something like ivabradine. But consider re-review whether they would benefit from PCI. And then also these patients, we'd start them on secondary prevention. So I always use the mnemonic, the 4 A's to remember that. So that's A for atenolol. We don't really use atenolol. It's more beta blocker. It's just to get you to think of a beta blocker. ACE inhibitor, so ramipril, atorvastatin, we would do 80 milligrams for a secondary preventative dose, and then aspirin. Once they've had their loading dose, aspirin then goes down to 75 milligrams. So then we come on to NSTEMI. So again, we do a GRACE score. GRACE score is one of these things that we never do in reality. It just looks good on paper and for exams. So always think about it in exams, but I don't think I ever saw anyone do it in like 4 months. Anyway, we do a GRACE score. If it's a high risk, so over 3%, and they're clinically unstable, so they're hypertensive, they've got signs of heart failure, etc., we think about immediate PCI, and we give them unfractionated heparin there and then. If they're just high risk, so again, over 3%, but they're stable, PCI within 72 hours, and we give them fondaparinux. Don't give fondaparinux if they're going for PCI within the next couple of hours. And then finally, if they're low risk, we do conservative medical management for those patients. The same again in unstable angina. I forgot to mention, make sure with these patients, whenever you do conservative management, always safety net them. So say if they're having symptoms, ask them to sit down, try not exerting themselves. If the pain's still there, then using the GTN, and then moving on to call A&E if the symptoms are still present. And then finally with STEMI, we're nearly there. STEMI is just symptom onset and PCI availability dependent. So you'll probably already know this. So if it's within 12 hours onset and PCI is possible within 2 hours, primary PCI just simply means they go straight to the cath labs. They don't go anywhere else. But if PCI is not available within 2 hours, then you would fibrinolyze, do an ECG again within 60 minutes to 90 minutes, and then reconsider PCI. But in reality, they're all going to be going for PCI. Right, next topic. So a tall and slender 53-year-old man presents to his GP with 3 weeks of worsening shortness of breath, which is affecting his sleep. He has a history of chronic kidney disease, hypertension, and osteoarthritis of the left hip. He takes ramipril and Adcal with nil drug allergies. During your examination, you notice the patient has a slight rhythmic head nod. Observations are as follows. So his respiratory rate is 21. He's saturating 97% on room air. His blood pressure is 156/61. His heart rate's 72. He's not got a temperature. What murmur would you expect on auscultation? So if Yed could put the poll up again. So I'll give you guys a minute. Okay, so I can see already, yeah, there's a good spread. Okay, looks like a few of you are getting it. Right, okay. Let's go through the answer. So the answer was D. It's early diastolic. So for those of you who put D, give yourself a pat on the back. So why was it D? So this man is suffering from aortic regurg, which is an early diastolic murmur. So why is it aortic regurg? So I hope you got a few hints there. So first of all, tall and slender. So whenever you hear tall and slender, think Marfan syndrome. So it's a connective tissue disorder. With connective tissue disorders, always think aortic regurg in the back of your mind. He's got worsening shortness of breath, which is one of the clinical features of AR. The rhythmic head nod, I was trying to hint, that's Demusit's sign. So aortic regurg is one of those ones that's got all those weird clinical examination findings. So because he's bobbing his head, that's Demusit's AR. And then with the blood pressure, he's got a wide pulse pressure. So that's almost a difference in 90 millimeters mercury there. So wide pulse pressure, that's also a sign of aortic regurg. Extra brownie points. Again, if you could say in the comments, do we think this murmur would be heard loudest during inspiration or expiration? When do we think it would be loudest? Okay, so I can see someone's gone for inspiration. Okay, so we've got some divided opinions there. Okay. Right, okay. So we've got a few going for inspiration, a few going for expiration. It would be during expiration. So it's left-sided. So I'll go a bit into, I'll give you something useful to help you remember in the future. So murmurs are the sound of turbulent blood flow, either due to a stenotic valve or a leaky valve. So I think to understand murmurs properly, it's useful to just go back to the basics and understand heart sounds in general. So I've included a link down there to a really useful video by Zero to Finals. Strongly recommend watching it. But essentially, so the first heart sound is when our atrioventricular valves close. So that's the tricuspid and the mitral valve. And they close at the start of systole to stop the blood flowing back into the atria. The second heart sound is when systole finishes, and it's when the semilunar, so the aortic and the pulmonary valves, are stopping the blood from flowing back into the ventricles. So if we think about it, systolic murmurs are going to happen in between the first and the second heart sound. Anything else is diastolic. So if it's between those, systolic, outside, diastolic. I hope that makes sense. Third and fourth heart sounds, I'll just briefly mention. It comes up time to time in exams, but I think it's pretty low yield. S3 is heard directly after S2, like 0.1 second. It's almost impossible to auscultate. Even Regis would struggle. It's the sound of the chordae tendineae twanging like a guitar string when the ventricle fills up with blood. The chordae tendineae being the bits of tendony, stringy wee bits that are attached to the valve. So it's normal generally in fit and healthy people under 30, but once you get above 40, 50, it's thought to be pathological, and it's generally a sign of heart failure, as the guitar string, if you think of it, is reaching its limit sort of sooner, if that makes sense. And then S4 is always abnormal. It's heard just before S1. And it's due to be thought to turbulent blood flow. So as the atria is pushing against a non-compliant, stiffened and hypertrophied ventricle. So it indicates heart failure. So how do we remember systolic versus diastolic? So I still use this to this day. So this is a really useful mnemonic. So I always remember systolic ASMR being that weird sleep stuff that people listen to. No judgment. So AS, aortic stenosis, and MR, mitral regurg. So just remember systolic ASMR, and then diastolic arms. I remember even for exams, I wrote the word diastolic on my arm just to get me to remember that, because that's aortic regurg and mitral stenosis, which are both diastolic. So just remember that. And as I said beforehand, so we've got the first and the second heart sounds. So we can see all the systolic murmurs are happening within those two heart sounds. So yeah, aortic stenosis there and mitral regurg. You can see aortic regurg and mitral stenosis are happening outside of those. In terms of whether it's left-sided or right-sided, so remember, left for expiration, right for inspiration. Right-sided murmurs being your tricuspid regurg or your pulmonary stenosis. Generally, the right-sided murmurs will mirror their opposite counterparts, if that makes sense. So aortic and pulmonary stenosis are both going to be early systolic murmurs. So just think of it in the same way, okay? And then again, just some high-yield facts for each type of murmur. So AS, ejection systolic murmur, just commit that to memory, radiates to the carotids. And in terms of clinical features, just think SAD. So think all aortic stenotic patients are SAD because they're going to experience syncope, angina, and dyspnea, breathlessness. For MR, so MR is a pansystolic murmur. It's thought of as a high-pitched whistling murmur, radiates to the left axilla. It's because it's a leaky valve, patients can develop symptoms of congestive heart failure because of that backlog of blood. And the causes are rheumatic heart disease, collagen disorders, so your Marfan's, an SLE, and post-MI complication as well. Aortic regurg, so that's what was in the stem of the question. So it's an early diastolic murmur. It's got some of the same causes, rheumatic fever, collagen disorders, bicuspid aorta though, that's independent. But then, as I said, it's got all these weird clinical findings. So it's got a wide pulse pressure. It's got a collapsing, or what's known as a Corrigan's pulse. So when you lift a patient's arm up, you'll feel their pulse, their radial pulse will become bounding. Collapsing doesn't mean it disappears. It becomes bounding when you lift their arm up. Quinks, which is the pulsation of the nail bed. And then demusit, the stupid way I remember it is like if you think of a headbanger and they're bobbing their head to the music. I know it's stupid, but it helps me remember it. And then finally, mitral stenosis. There's not too much to remember for this except malar flush. So they'll get that perfect sort of butterfly distribution rash. And then they can have P mitrale. So a bifid P wave on their ECG. So just remember those. Okay, third question. So a 47-year-old man presents to A&E with sudden onset tearing chest pain that radiates to his back. He has a heart rate of 105 BPM, a BP of 152/76, no signs of end organ ischemia. He has a past medical history including hypertension and ischemic heart disease. A CT thorax abdomen pelvis is ordered and confirms the suspected diagnosis as a false lumen is seen in the descending aorta. What is the definitive management? So again, if Yed can put up a poll, and we'll give it a minute or so. Okay. I think good result. Okay, yeah, in the interest of time, let's reveal the answer. So most of you actually got that. So yeah, the answer is D. So I hope you were able to suss from this that this patient, yeah, is having an aortic dissection. So we can see from the question, yeah, so typical presentation, if soon as you hear tearing chest pain, think aortic dissection. It's more common in descending to have tearing, but anyway, it radiates to his back as well. Important to note, he's got no signs of end organ ischemia, so it's uncomplicated. He's got a risk factor of hypertension, which is a big risk factor, and it's in the descending aorta. So the descending aspect is key because that will impact on it's termed as a Stanford type B dissection. So we'll get into why specifically it was D. So aortic dissection is when there's a tear or a break that forms in the inner layers of the aorta wall. So you've got three layers. You've got the intima, the media, and the adventitia layer. Where the tear happens, where the false lumen presents, is in between the intima and the media. Key main points for exams to remember. So if there's a greater than 20-point difference in blood pressure between the arms, that's a sign of aortic dissection. Hypertension is a big risk factor. You might hear a diastolic murmur on examination because it can cause aortic regurg, which is a sort of late presentation find. It can present with focal neurology. So sometimes you get patients who are experiencing paraplegia in the legs or change in sensation, even sometimes critical ischemia in the legs. So that's if there's involvement of the spinal arteries. So yeah, that's generally a late sign, but it's something to keep an eye out for. Hypotension is a sign of progression. So again, it's a late presenting find in these patients. So it's generally a poor prognostic factor. In terms of investigations, chest x-rays, it's non-diagnostic, but it's going to help you to build a picture. It will show a widened mediastinum. A CT angiogram, chest, abdomen, pelvis, that's the gold standard. However, if the patient's too clinically unstable and you think they're not going to be able to stay still in a CT, then you can go for a TOE, a transesophageal echo. So yeah, getting to the classification. So there's two types of classifying systems. There's Stanford and there's DeBakey. I, for exam purposes, only listen to Stanford. DeBakey is the one where in the image there, it goes type 1, type 2, type 3. It's just to make you aware of it. It's, I think, type 1 and 2 in a grade the ascending aorta, and type 3 or 4 are about the descending. Just pay attention to the Stanford for exam purposes. So Stanford A being if there's any involvement of the ascending. So even if you've got it in your ascending and your descending, it would still be a type A. Type B is when it's just confined to the descending. So then, yeah, in terms of management, so for type A, we would opt for surgical management, most likely via open repair. So that's going to involve midline stenotomy, and you're replacing the ascending aorta with a synthetic graft. And in the meantime, up until you get that patient there, you're going to control their blood pressure and their heart rate with IV labetalol. IV labetalol is just the one everyone uses. And it's just to control the exerting pressure on the aorta in the meantime, because obviously they're quite high risk. These patients are managed surgically because I think there's a 50% mortality in 48 hours if these patients don't receive any surgical intervention. So these guys are high risk. Type B, we're less concerned about. We're just going to manage them with labetalol. We're going to control their blood pressure, control their symptoms. They can go for surgery if we think there's signs that they're clinically unstable, they develop focal neurology, etc. But most of the times it's going to be conservative. So, question 4. A 67-year-old...
You just have one question, sorry.
Oh, yeah.
Just have one question in chat, by the way. When would you do a TOE over a CT chest abdo-pelvis?
So a TOE, so as I said, it's when you think the patient's clinically unstable. There's a TOE, and then there's an abdominal ultrasound. Abdominal ultrasound is going to be non-diagnostic. It's going to let you know that it's there. TOE is going to be diagnostic. And again, it's if the patient is clinically unstable. So they've got signs of hypotension, they're tachycardic, they're developing signs of heart failure, etc. They've got critical limb ischemia. So yeah, if you think a patient, because just appreciate when you send someone to a CT, they're going to have to be still for about 15 minutes or so, and you're not going to be able to do any urgent intervention. So just look at them from the end of the bed and say, is this patient going to be all right for the next 10 to 15 minutes? If not, do a TOE, because that's much quicker. Does that make sense? Okay.
You've got one more.
Okay,
would the
yeah.
difference in blood pressure? Sorry, would the difference in blood pressure also show coarctation of the aorta?
Oh, now you're testing me. I think, yeah. When they say difference, do they mean difference between the arms or a wide pulse pressure? What are they saying?
Just
there?
waiting for more details, I guess.
The difference between the arms, I think, because we said in the stem of the question, if I go back, yeah, so I don't think I'd said it there. But the answer is yes. Yes. If you find a difference between the arms as well, then yeah, that's a sign of aortic dissection. Yeah, it's there in the key points. The first point, yeah, a difference of greater than 20 millimeters mercury between the arms is a sign. Yeah, that answers. Any more questions? I can't see the chat right now, so I'm just relying. Right.
That's all.
Yeah. Oh, did someone have one there? Did someone come onto the mic?
No, I think that's all.
All right. Okay. Right. I'm going to go into question 4. So, 67-year-old woman presents to A&E with a 4-day history of fevers and rigors. She's also noticed she's got some new onset thoracic back pain today. She has a past medical history of childhood rheumatic fever, hypertension, and aortic valve replacement 3 weeks ago for severe aortic stenosis. On examination, you note some painless erythematous macules on the femur eminences and hear a diastolic murmur over the aortic valve. What is the most likely causative organism? This is a typical exam question, so I'll give you guys a second. Okay, seeing an interesting spread. So yeah. Okay. Right, yeah, I think some of you are starting to get it. Right, let's look at the answer. So, answer was B, Staphylococcus epidermis. So, this is just like a typical exam question. It's come up in final papers like a lot. I think I even had something like this. So the most common organisms have switched around. So yeah, this was infective endocarditis. Why? So she's presented with fevers and rigors. These patients can present really variably and generically. So always have in the back of your mind, if someone's presenting with pyrexial symptoms with no clear cause, these patients will just generally feel rubbish. But I hope there's some more clues in there. So she's got some thoracic back pain. These patients are prone to developing discitis, which that could be hinting at. She's had some previous rheumatic fever and recent valve surgeries. Those greatly increase your risk. The painless erythematous macules on her hands, I hope you sussed were Janeway lesions. And finally, she's got a diastolic murmur, which is probably because the infection is now in her new prosthetic valve, which is causing some retrograde leaking, so some regurg. So why Staph epidermis? So this is so Staph aureus is the most common bug. Now it used to be Strep viridans, but it's now Staph aureus. But because she had valve surgery within the last 2 months, so it's recent, so it's within 2 months, it's most likely Staph epidermis. So let's go into why. So infective endocarditis. So this is a life-threatening infection of the endocardium, i.e. the inner lining of the heart. And it's usually, not always, but usually situated around the valves. It's most commonly bacterial, but again, not always. It can be fungal, or it can even be seen in SLE. It's usually as a result of a bacteremia, so bacteria being present elsewhere in the blood that have found their way to the valves. However, there's other risk factors that can increase someone's susceptibility. So, for instance, valve surgery. So if you're directly introducing pathogens of bacteria, less than 2-month-old prosthetic valve. So why 2 months? So valves, whenever you put a device inside a heart, it undergoes what's called endothelialization. So it forms its own endothelial layer after 2 months. But before that time, it's susceptible to Staphylococcus epidermis. So that's why within that 2 months, it's most likely staph epidermis. If patients are IVDUs or if they've had recent dental procedures. However, the endocardium is usually protective against the bug, and it forms its own protective layer. So then if we have damage or insult to this layer, that could also facilitate infection. So that's how I've split the 2 risk factors. So for that, we're thinking previous valve disease, so in stenosis, or if there's any sort of turbulent blood flow, that will damage the valve, congenital heart disease, hypertrophic cardiomyopathies, and previous or chronic inflammation, so an SLE or rheumatic fever. So these are the causative bugs. Just try to commit these to memory because these will come up. So the most common, as I said, is Staph aureus. As I said, less than 2 months, Staphylococcus epidermis, poor oral hygiene or dental surgery. Think Streptococcus viridans. It used to be the most popular, but no longer. It's more present in developing countries. Viridans refers to a group of bacteria, so it's not a specific bacterium. So mitis and sanguineus is part of that group. And then lastly, if somebody has Streptococcus bovis, you have to screen for bowel cancer. It's just one of those weird past med things. It's associated with bowel cancer. And then how are they going to present? What's the signs and symptoms? So again, as I said, it can present really generically. They'll describe themselves as having a persistent fever and persistent fatigue. They'll feel really run down. They'll have chest pain for obvious reasons. They might have hematuria if there's renal involvement. In terms of signs, Roth spots you'll see on fundoscopy, as they'll appear as small. You can see there on the fundoscope, they appear as small, white-centered retinal hemorrhages. Don't confuse Janeway lesions and Osler's nodes. So Janeway lesions are microemboli on the hands, so they shouldn't be painful. So they're painless. There's no reason they should be painful. Osler's nodes are generally located on the fingers, and they're thought to be localized immune responses. So and hence they're tender. So tender, non-tender. Okay. Hope that helps you remember. And then in terms of actually diagnosing, because it presents so generally, we follow modified Duke criteria in order to make a diagnosis. So you can see there, you've got a different combination of when you can rule it in. So if they meet any of the pathological criteria, instant diagnosis. If they have 2 major criteria, 1 major, 3 minor, or 5 minor. In terms of the specific imaging findings at the end of major, that's going to be on an echo. A vegetation, by the way, is a clump of infective bacteria held together by fibrin and platelets, if you're just wondering what that is. And then for the minor criteria, vascular phenomenon, so that's going to involve major emboli, splenomegaly, clubbing, splinter hemorrhages, Janeway lesions, and any petechiae. Immunologic phenomena, so that's glomerulonephritis, as I said, if you've got renal involvement, Osler's nodes and Roth spots. Then finally, microbiological evidence. That just means a blood culture that didn't meet the standards of the major criteria. Okay. If there's any questions, put them in the chat. Otherwise, we'll move on to question 5. So, a 39-year-old man presents to the ward complaining of new onset palpitations. Moments later, he becomes unresponsive. There is no palpable pulse. CPR is started and defib pads are attached. The following is shown during the first rhythm check. What is the next step in your management? So I think you had started the poll. Have we got the poll going there yet?
Oh, sorry, just give me 2 seconds. Sorry, internet issues. Apologies. All right, should be going out.
Yeah. Okay, yeah. I think most of you have got it. So let's show the answer. So it is answer D. So I hope you were able to guess. Yeah, so this guy is obviously in cardiac arrest, but he's got what looks to be on his rhythm strip normal electrical activity, but he's not got a palpable pulse. So I think those of you who got D were able to pick out. So yeah, he's got PEA, pulseless electrical activity. I know this wasn't nice, not giving you a full ECG, but in reality, you're not going to have a full ECG. This is what you're going to see on the DFib machine. But yeah, we'll go into why was it option D. So this is from the the 2021 guidelines from the Resus Council UK. It's pretty good in terms of differentiating how we manage a shockable versus a non-shockable rhythm. My problem with this algorithm is it doesn't really tell you when to use what medications and when. So thankfully they've also provided a chapter in their advanced life support booklet, which is there on the right. So I've summarized this on the next slide as well. So this is a summarized version of how to manage shockable versus non-shockable rhythms. So imagine, so we've started CPR, and then we get to the first rhythm check, and we've identified VT, pulseless VT, or VF. So we identified a shockable rhythm. So in that instance, we would then do a first single shock of unsynchronized DC cardioversion. In the reality, or in the scenario where they've already got DFib pads and they're in a PCI center and you watch them, you physically see them have or go into VF or pulseless VT, that is when you would do 3 successive initial shocks. In reality, that will almost never happen. It only really happens when patients are undergoing PCI and they've got the pads on because they're sort of assuming they're going to go into VF or VT. They're at high risk. Anyway, so we've done the first shock. We do 2 minutes of CPR, and then we get to the next pulse check. They're still in VT or VF. We do another 2 minutes, and then we get to the third rhythm check. They're still in. So after the third shock, that is when we give the 1 milligram adrenaline and we give amiodarone 300 milligrams. So after the third shock. After that third shock, we continue CPR, and then we do a rhythm check every 2 minutes, regardless of what stage of rhythm check and CPR we're at. We keep giving the adrenaline every 3 to 5 minutes. And with the amiodarone, so we're only giving it twice the amiodarone. We give the first 300 milligrams. The second 150 milligrams we give after the 5th shock. So we only give amiodarone twice, okay? And essentially we keep doing this until the patient develops a pulse or signs of life, and we achieve ROSC, which is the return of spontaneous circulation. For asystole, it's a little bit different. Asystole, we're going to keep doing until the patient goes into a shockable rhythm. It's unlikely you're going to be able to resuscitate a patient in a non-shockable rhythm. And then once we get them into a shockable, we switch into the other algorithm on the left. Anyway, so we've got a non-shockable on the first rhythm check. We immediately give them adrenaline. We do 2 minutes of CPR. We check the rhythm in another 2 minutes. They're still in asystole or PEA. So we just keep giving adrenaline every 3 to 5 minutes. I hope that sort of made things a bit clearer. So if we go back to the exam question, so yeah, it was option D. So this patient's in PEA, immediate adrenaline. I hope that clears things up a bit. And then finally, so this is more gauged towards an OSCE station if you ever had to manage a cardiac arrest. I have heard of it before, but I think this is just really good to know as well. So this is for the individual who's going to be standing at the end of the bed leading a cardiac arrest. So it's usually the most senior doctor, and they're going to run through the 4 H's and the 4 T's of reversible cardiac arrest. So we think hypoxia. So we're going to look at recent trends. Have they been hypoxic recently? Ensure somebody's ventilating them adequately. We look at hypovolemia. So again, look, are there any recent signs of trauma, any signs of bleeding? Think on the floor and 4 more. Hypothermia, take their temperature. If they're cold, think about a bear hugger, which is this inflatable blanket. Some hospitals have it, some don't. We can give them warmed IV fluids, or we can retrofill their catheter with warm saline. And then hypokalemia, you are not going to get a radial pulse in a patient who is pulseless. So you're going to have to go for their femoral, so a femoral stab. And then in terms of the T's, so tension, if you're thinking of tension pneumothorax is the cause, get someone to auscultate and percuss the chest during the 2 breaths or during the rhythm check. If it's a tamponade you're worried about, again, think of recent history of trauma or surgery and get a bedside echo. That's the only thing that's going to confirm it. A thrombus, again, look for a history of any recent clots. So if they've got a PE, if they had any chest pain recently, any ACS, if they've got any signs of a DVT, any swollen calves. One thing with a thrombus, once you thrombolize, you then have to keep doing CPR for 60 to 90 minutes. And that's a lot of time to be doing CPR for, so just be careful. And then finally, toxins. So is the patient in IVDU? Check their pupils if they're constricted, check their recent drug history and their drug chart. And yeah. Okay, so I'll hand over to Yed now. So I think I went over a wee bit.
Hi, can you...
Sorry, there's just a couple of questions that have come through about
the
question. The first one is, any idea when to give a synchronized versus an unsynchronized shock?
Yeah, so synchronized and unsynchronized. So just think, unsynchronized is defibrillation. Synchronized is where, so that's your DCCV. So that is when you're trying to get a patient, for instance, out of atrial fibrillation. So they're not having a cardiac arrest, or it's when someone is in SVT. And it has to be synchronized to the R wave. So yeah, just remember, unsynchronized is defibrillation. And then yeah, there's a whole host of indications for synchronized cardioversion. I hope that answers your question. Was there any others?
There's one more, but I think it's been answered in the chat. So.
All right. Okay. Cool. Anyway, I will hand over to Yed.
All right, can you hear me now? Ross, can you tell me?
Yeah, all good.
Okay, perfect. My internet's been cutting out the last few minutes, so just let me know if something goes wrong when you can't hear me. All right, I think, can you take the poll? Oh no, I just closed the poll. Perfect. So I've got a couple of questions as well. I'll try and get through them reasonably quickly, so you guys don't need to sit here until very late hours. But hopefully they'll be useful. So the first one, 15-year-old student presents to your office on advice of his football coach. He started playing football this year and suffered a syncopal episodes at practice. He was sprinting with the rest of the team and became lightheaded. He lost consciousness, fell to the ground, regained his consciousness within 1 or 2 minutes. No. And on exam, you hear a systolic murmur. at the left lower sternal border and apex, and you've got some changes on the ECG. So what would you expect to hear on examination? All right, let's give it a minute. Try to get a few more answers. Okay, I think we're moving in the right direction. Okay, so the general topic of this question is cardiomyopathies. So generally, if you've got a 20 or a teenager-year-old person doing some sports and passing out, you think of a cardiomyopathy, so likely a genetic cause. So can I have the next slide, Ross? Sorry. So the correct answer for this will be A, as many of you have chosen. So what we're thinking up here, why are we thinking this is the correct answer? The most common question as such will obviously point towards hypertrophic cardiomyopathy. And I'll explain the findings of hypertrophic cardiomyopathy in a second, which will obviously explain the question as well. So can I have the next slide? Right, so when we're thinking of cardiomyopathies, we've got several different types. The most important one is obviously the hypertrophic cardiomyopathy. So that's your average teenager, 20-year-old, who just out of the blue kind of passes out, generally on exertion. Then we'll talk quickly about dilated cardiomyopathies, and then we'll say a few words about the other two types, the arrhythmogenic cardiomyopathy and the restrictive cardiomyopathy. So the first thing that we talk about is the hypertrophic cardiomyopathy. So here we're talking about hypertrophy, so thickening of the myocardium in absence of another cause. We're talking about aortic stenosis or hypertension. That's why it usually affects younger people. It's the most common cause of sudden cardiac death, and it's usually autosomal dominant in terms of inheritance, or can be inherited in syndromes. I don't know if you've heard of Fabry's disease, so disease of the lipoglycosides, or Pompe's disease, so glycogen transport disease. Your clinical features would be, if you were to cut out and put it under a microscope, just a small biopsy, it would be hypertrophy and disorganization of your myocytes. So you'd have chunky big cells, but the organization will be off if you looked at it and compared it to normal heart muscle. And it will be particularly affecting the septum. The septum, as you can see on the image, that septum also at the same time anatomically is quite close to your to the valve, to the aortic valve, which is sometimes you've got the subtype of hypertrophic cardiomyopathy, which is called hypertrophic obstructive cardiomyopathy, which is when the thickening of the muscle is such that it also causes impairs the outflow. We've also got issues with systolic motion of the mitral valve. So sometimes the mitral valve might not close properly, and in fact might additionally add up to the outflow obstruction through the aortic valve. Symptoms. So generally, the symptoms are not really very evident. Most people are completely asymptomatic. If someone is lucky to be symptomatic, so that it gets picked up early and you can do something about it, they present with symptoms generally similar to aortic stenosis. So that would be your chest pains, as Ross mentioned, a dyspnea, can be the syncope. You can get arrhythmias, and in many cases, people have gone through life with it as asymptomatic, and unfortunately, in some cases, it results in just sudden cardiac death. Signs, so that would be the double apical pulsation. So you can hear, as Ross mentioned before, the S4 sound. So that sound just before S1. That is because the atria are trying to forcefully additionally contract, which produces the S4. As you can imagine, the the left ventricle is quite beefy, quite strong. So you've got a very jerky, kind of strong carotid pulse. You'll have an ejection systolic murmur, and that's the important thing. So the ejection systolic murmur is increased with maneuvers that decrease afterload, such as standing or Valsalva. So any maneuvers that pull the blood kind of far away and decrease your afterload, decrease your blood pressure, will increase the murmur. And the murmur will be decreased by maneuvers that increase preload, such as squatting, for example. So they'll result in more blood being transferred to the ventricle. The ventricle will fill much better, and the outflow obstruction will be much smaller because of that dilation. When you look at it in investigations, you're going to see left ventricular hypertrophy on the ECG. Echo, which is usually diagnostic, will show you this asymmetrical thickening. You can do MRI as well, and the important thing is to do genetic analysis, especially if you've got some family history. Regarding management, there's two key things if you've got someone. First, so the main aim in terms of management of your hypertrophic cardiomyopathy is to keep the preload high. So you want to keep that ventricle nice and distended, filled up nicely, so that there's no outflow obstruction through the aortic valve. You can do that by two main strategies. The first one, the simple one, is making sure that the patient's always really well hydrated. So the reason why the syncope episodes happen usually in sports is that you get really dehydrated, which increases the outflow obstruction. You get your shortness of breath, you get your chest pain, and then you just pass out. And then you can also treat it medically by increasing preload via beta blockers or calcium channel blockers, which obviously slow down your heart, enable your ventricle to fill in much faster, much fuller, and then therefore increasing the preload and decreasing the obstruction. Can you go back the slide, please, to the questions and the answers? So as you see, that basically correlates with answer A. I'll just quickly go through B, C, and D. So I would normally ask you about, just in order to save time, I'll just quickly explain. So answer B is a typical murmur for mitral valve prolapse. So it's a mid or late systolic click. Choice C is mitral regurgitation. D, tricuspid regurgitation, and E is aortic stenosis. But I think Ross covered a fair bit, so I'll not go further into it. Can you go 2 slides forward? Sorry. Right, so this is just a good table. I'll just quickly talk about the other types of myopathies. So the next one will be, it appears in questions quite rarely. That's why I'll only say a few words about it. Is the it's not here on the table, it's the arrhythmogenic cardiomyopathy. So it usually affects the right ventricle. It's also basically your muscle is replaced with fatty tissue. And then since that's a fatty tissue and not muscle, your right ventricle gets dilated. With dilation, you usually get arrhythmias because your conduction is not synchronized anymore, and you can eventually get your right ventricular failure. Clinical features with myopathies are generally very similar for all of them. So most are asymptomatic, and then if you get symptoms, depending on which ventricle is affected, you end up with syncope. You can have sudden deaths and arrhythmias, and in this case, obviously, you can have right heart failure. In this cardiomyopathy, your ECG will be normal. Echo is the really good diagnostic tool, which can show you your right ventricular dilation. But you'll see a lot more if you do a cardiac MRI, because you'll be able to tell that the muscle is not quite muscle, that there's some fibrofatty tissue. And your gold standard for diagnosis is just genetic testing. And since it leads to arrhythmia, you're going to use your drugs to prevent arrhythmias. So you're going to start with beta blockers if you are non-symptomatic. And then you can move to stronger drugs. You can move to amiodarone or sotalol, which is a beta blocker with some potassium channel blocking activities. And then if you're worried of life-threatening arrhythmias, you can implant an ICD. So the third type that comes up in questions quite often is the dilated cardiomyopathy. That is usually not genetic, so you would look for additional causes. but it also can be genetic, but it's a much rarer genetic cause than for hypertrophic cardiomyopathy. So with dilated cardiomyopathy, you've obviously got dilation of the chambers, and because you've got dilation, you've got worsened systolic function. The usual cause is your kind of alcohol consumption for 40 years. Chemotherapy, so doxorubicin is a medication that commonly is associated with dilated cardiomyopathy. You've got your tropical diseases, so parasites, Chagas disease causes dilation. And then you've got many, many more. The clinical features, it basically presents like heart failure. So you've got your impaired heart pumping. Because it's dilated, all the circuits that work in a normal heart are somehow off in terms of synchrony. So you can just have some arrhythmias and conduction defects. Because the heart isn't squeezing very well, you can get some thrombus in the ventricles and result in emboli. And obviously, sudden death is associated with all cardiomyopathies. And the good test here is an echo, which will show the dilation of the ventricles and poor general function. And then management for it is the same management as for heart failure. So medical management, which we'll talk about a bit later, and you can implant your ICD. The fourth type and the last that I want to talk about is the restrictive cardiomyopathy. So it's kind of like you look at the heart and it looks fairly normal. But for some reason it really expand very well. It's usually caused by just fibrosis of the heart wall. Most commonly it's associated with amyloidosis or sarcoidosis, but can also be genetic. Features are very similar, so dyspnea, fatigue, edema, and on examination you're going to have some nice signs. Ascites edema. Once again, you're going to do your ECG. Your heart's not going to be pumping very well, so your QRS will be low in terms of voltage. Your cardiac MRI will be a good test, which will show you that fibrosis. But biopsy is probably the best test to confirm the diagnosis. In terms of management, you try and treat your amyloid and sarcoid as appropriate. But in other causes, often transplantation is the only kind of effective treatment. Can I have the next one, please? And here, what I just wanted to touch on is the kind of the acquired and usually reversible two cardiomyopathies. The first one is your Takotsubo, which basically presents like a heart attack. But when you do an angiogram, you don't see obstruction in your coronaries, but you see this weird shape of the heart. So hopefully on the image you can appreciate. On the left side you've got in diastole, so it looks fairly normal, slightly abnormal, but you know hearts generally look different in everyone. But then in systole on the right hand side, you can see that the basal part of the heart is pumping quite well, but then you've got this ballooning or dilatation. Those are the key words in terms of your apical part of the heart. So it doesn't really squeeze too well. So that's Takotsubo cardiomyopathy. It's generally reversible within 4 to 6 weeks. You can aid the symptoms with beta blockers. Generally affects middle-aged women. We don't quite know what causes it. We think it's related to stress, so elevated level of catecholamines, but we're not quite sure. But the most important thing is that it's in most cases reversible and not really associated with frequent recurrences. And then the last one is peripartum cardiomyopathy. So in women who are in the last trimester or within 5 months after delivery, they're at risk of dilated cardiomyopathy, but they usually recover within 6 months. But that's also something that's quite important if you've got a question about a pregnant lady who's got some heart issues. Okay, can I have the next question? All right, question 7. So you've got a 55-year-old man this time, who's getting progressively worsening shortness of breath and some leg swelling that occurred when he was on a business trip. He has a diagnosis of a congestive heart failure, and he's symptomatic with it. His blood pressure is 140/90. There's no jugular venous distension on Gallup, so there's no S3 or S4, and he's got only minimal swelling. His echo shows ejection fraction of 45%. He's currently on aspirin and a statin. He doesn't like taking too many medications, which is quite common. So what additional treatments are indicated at this time? Okay, perfect. So the correct answer, can I get the next slide, sorry? So the correct answer is B. So hopefully we can all appreciate that the patient, as the question says, has got heart failure. The very important thing is that he's currently becoming symptomatic, so we do need to do something about his treatments. And we'll talk about all the medication, but generally the first medications that we start in order to improve someone's treatment will be an ACE inhibitor and a beta blocker. We can start all of the management. All of those management options are available and are used in patients in heart failure. Unfortunately, those questions try and trick you and try and ask you for which ones you would introduce in what order. The first thing would generally be an ACE inhibitor and a beta blocker. Spironolactone, so an aldosterone antagonist, is something that we use frequently as well, but that's for people with a lot more significant heart failure, generally class 3 or 4. So your ejection fraction is expected to be under 35%. And you introduce it in patients who are already on an ACE inhibitor and a beta blocker. Digoxin can be used to control arrhythmias, but this would be something kind of that we don't really have in this question. Furosemide can be used if we've got evidence of edema. All the other medications, we started them and we're still struggling. Interestingly enough, whilst furosemide helps you with your symptoms, it doesn't really increase your mortality. So it can help you with the pedal edema or help you with the breathing. But at the moment, there are better options for it. Can I have the next slide? Right, so we'll just quickly talk about heart failure. The most important thing about heart failure is that it's not a diagnosis, it's not a condition itself. So it's a syndrome that results from either structural or functional cardiac disorder. So if you've got someone with heart failure, it's incredibly important that you still look for the cause, because you might be able to treat the cause and then improve someone's heart function without necessarily having to start them on the heart failure medications. Heart failure is kind of a vicious cycle. So at the beginning, when your heart function starts dropping, you activate all these mechanisms to try and improve the way your heart works. And those mechanisms work really, really well at the very beginning. But unfortunately, as you keep adding, increasing your age, or keep adding your risk factors, or keep your blood pressure high, keep smoking, or have a heart attack, those risk factors eventually overwhelm those mechanisms, those corrective mechanisms. So some of the main mechanisms, for example, is the release of the atrial natriuretic peptide, which causes natriuresis, diuresis, and vasodilation. At the same time, as you've got decreased renal perfusion in someone who's got heart failure, you increase the production of the renin, and then you activate the renin-angiotensin-aldosterone pathway, which, as it says here, leads to vasoconstriction and then leads to salt and water retention, and then that creates that vicious cycle. You also, as you pump less out of your heart, your carotid bodies feel like you're being in kind of more of a hypotensive state. So your sympathetic system is stimulated, tries to make your heart pump harder and quicker, but that gets overstimulated, leading to myocyte exhaustion and apoptosis, which further obviously contributes to your heart failure. And lastly, as you're pumping less, you have peripheral vasoconstriction, because you obviously try and preserve the blood flow to your important organs, to your brain, to your gut, to your liver, and throughout. So you've got an increase in afterload, which further decreases ejection fraction, which causes further ventricular dilatation. So as you can appreciate, it's so in terms of different types of heart failure, so we generally have two. Sometimes you can encounter the third type, which is just the in-between of the two. So you've got your heart failure with reduced ejection fraction, which is the same as a heart failure with systolic dysfunction, which generally occurs when your ejection fraction is below 40. The most common causes are heart attacks, issues with your valves, hypertension. And then you've got your heart failure with preserved ejection fraction, so ejection fraction about 50. That is usually due to hypertension, because the stiffness of the ventricular wall, and decreases the ventricular compliance. So it decreases the ability of your heart to relax, which then impairs your diastolic function. And then the third thing is this heart failure with moderate ejection fraction, which is literally when your ejection fraction is between the 40 and 50, but something a bit more recent. Symptoms generally depend on which ventricle is affected. So if your left ventricle is affected, then you're going to get symptoms primarily of pulmonary nature. So you're going to have your exertional dyspnea, you can have your paroxysmal nocturnal dyspnea, you can have your cough as well. If it's your right ventricle that's affected, you can have your ascites, peripheral edema, and such. When it comes to signs, you have tachycardia, elevated JVPs. Can I have the next slide before that? Thank you. So you've got your cardiomegaly, so the increased cardiothoracic ratio. So your heart becomes more than 50% of that thoracic diameter. You've got your third and fourth heart sounds. Third heart sound, particularly if it's heart failure with reduced ejection fraction. So if it's reduced ejection fraction, it leads to cardiomegaly, your heart dilates, and you end up with a kind of like a dilated cardiomyopathy, hence the S3. In heart failure with preserved ejection fraction, you've got that stiffness, so you end up with the S4. You've got your bibasal crackles, pleural effusions, you've got the curly B lines, which you can see if you're really good with chest x-rays. I always struggle. You've got your peripheral ankle edema, ascites, and hepatomegaly. Regarding investigations, if you want to just diagnose heart failure, the syndrome, the test that we usually do is BNP, which is elevated and is released from your ventricles. And then what you do, obviously you can do a chest x-ray and an ECG, which can show you that someone's in heart failure. But what you really want to do is try and look for underlying cause. So you do an ECG and look for signs of ischemia. You look for an arrhythmias. You can do an echo just to look at your valve function. You will also look for signs of previous MIs by looking at wall motion abnormalities. And then if you can't find anything, you can do cardiac catheterization, or you can do a cardiac MRI or a nuclear scan to just look at that muscle even closer. Can I have the next slide? And then the very important thing is your 4 pillars when it comes to treatment of your heart failure. So don't forget about the first thing, which is just what you do in terms of conservative management. So the first thing is trying to limit sodium intake. So try and stimulate the diuresis so that people are not in retention. But then you quickly move on to treatments. So like I said, the first thing you do is start them on the beta blocker, and then you can start them on an ACE inhibitor or an aldosterone receptor blocker if they have a reaction to the ACE. You then move on to an aldosterone antagonist. So you've got your 2 options. Generally in use, you've got your spironolactone and eplerenone. Spironolactone, you have to be always cautious of the side effect, which is gynecomastia in men. And then you've got your SGLT2 inhibitors, so your empagliflozin and dapagliflozin. You might be familiar with them, and if not, you might be familiar with them since they're diabetes medication, but they were shown to promote diuresis and generally help with heart function. You also have this new class of medications, which is called neprilysin inhibitors, usually in a combination with an A or B. So it's your sacubitril valsartan, or sac-val, as you might encounter it on the wards, which is something that we introduced after we have all the 4 pillars, but we still can't really control the heart failure well. So we can introduce that instead of the ACE inhibitor or the ARB. And then, like I've mentioned, furosemide or bumetanide are your loop diuretics, just for the symptomatic relief, so just to offload some fluid, but don't really use them in the long term if you don't have to. And after you obviously got your intervention, so more surgical method, you can use cardiac resynchronization therapy. So basically, as your heart dilates, as I said before, you're at the risk of getting into arrhythmias. So you want to put in a device that will resynchronize your heart in case your ventricles start pumping somewhat independently. So you can implant a CRT device, which simultaneously will pace both ventricles if they go out of rhythm. And then you can add an ICD, and that becomes a CRTD, in case they also get into an arrhythmia, so that shock can be diverted, bringing them back to normal rhythm. Could I get the next question? Right, so question 8. We've got an otherwise asymptomatic 65-year-old with diabetes presenting to your A&E with a sports-related right shoulder injury. His heart rate is noted to be irregular, and you do an ECG and you see this. What is the best immediate therapy? Okie dokes. So, can we move on to the next slide? Just for the answer. Right. So if you look at the question, there is a few very important key bits of information. We've got someone who comes in asymptomatic, comes into A&E with a completely unrelated issue. And we kind of incidentally, as we do our basic OBS, just as we do our basic ECG, we notice that his heart rate is slightly irregular. We do an ECG, and this is what we see. That's just the basic kind of bit of information, and I hope that we can appreciate that we're in certain kind of heart block. Just because we can see that we've got some dropped heartbeats, then it means that it's not first degree heart block, which I'll talk about in a second. But then we look at it and we see that we've got some drop beats. So then the next thing we look at is whether there's correlation between P waves and QRS, which I hope you can see that there is. So there's the P wave before every QRS. So we look at heart block. And now the second thing we look at is whether the PR interval gets longer and eventually there's a skipped heartbeat. And I hope we can appreciate that. At the beginning, we've got a very short PR interval. It gets a little bit longer, and then there's a skipped QRS. So we're in the Mobitz type 1, so the Venki-Bach a second degree heart block. So usually with your first and second degree heart blocks, unless they're asymptomatic, you don't need to do an intervention. You have to remember that even though it doesn't look nice, that the heart rhythm doesn't look nice, and you really want to fix it, and the fix for it is quite easy. Every single intervention is associated with side effects. So if someone is asymptomatic, you generally, the first thought that you should have is, do I need to do anything about it? And in the case of asymptomatic first and second degree heart blocks that generally produce a normal kind of heart rate, you are not required to do anything about it. When we talk about third degree heart blocks, that's a completely other issue. Can I have the next slide, please? So when we talk about heart blocks, I'll just quickly get through it. You've got your first degree heart block, which just means that your PR interval is prolonged. So it's more than 0.2 seconds. Means that every atrial depolarization is followed by conduction of the ventricles, but there is some delay. You've got your second degree heart blocks, means when some POAs are conducted, but some POAs are not conducted. You've got your Mobis type 1, so the VencuBack, which means that your PR interval gets progressively longer until a P wave fails to conduct. That means you've got some issue at the AV node, and generally you can just go with observation, as in this case, unless obviously we're talking about someone who's fairly symptomatic. You've got a Mobis type 2, where the drop complex is not preceded by progressive PR interval prolongation, and usually your QRS complex is wide. So it's above 120 milliseconds. That means that your block is below the AV node, usually at the His bundle, and just at the same time, it requires pacing if it's symptomatic. The second degree heart block is often caused by inferior MIs, because as you might know, the right coronary artery, which correspond to the inferior territory, supplies the AV node. And then you've got your third degree heart blocks, which basically means that there's no synchrony between atria and ventricles. And with those, you definitely need to, and the main thing to do is establish basically what's the cause, what's the etiology. It's usually an MI, and usually you can treat it with a pacemaker. And then you've got your, can I have the next slide, sorry. So that's something that I've always been struggling with, because you notice them quite often, and quite often also there's just nothing that they kind of apt to in terms of your diagnoses, but they're quite a common diagnosis. So as you might know, the His bundle, once it goes distally, it gives rise to first the right and then the left bundle branches. And then the left bundle, because it supplies that big left ventricle, it has to subdivide into the anterior and posterior divisions. If you've got a complete bundle branch block, so either your left or your right bundle branch blocked, that means that your propagation of that signal throughout your ventricles is slower, so you can expect your QRS complex to be wider, so above 100. And you're probably looking at your QRSs. So you've got that classic marrow shape. So you've got an M in a V1 and what looks like a V, it looks like a W in your V6. So if you've got an S wave in your V1 and your V6, in your V1 and an S wave in your V6, bundle branch block, you've got the opposite. So you've got the William structure. You've got a deep S wave in V1 and a tall V6. They're usually asymptomatic, like I've said, so usually you'll do an ECG and you'll get this right bundle or left bundle branch block, but they're usually asymptomatic. In questions, if you've new onset, a new left bundle branch block, you've got to be careful if it's an MI. So you also always look, once you get to clinical practice, you always look at previous ECGs, whether that left bundle branch block was already present. But for question's sake, you have to be careful if you've got someone with a new left bundle branch block. And regarding the causes, so your right bundle branch block is usually congenital abnormality in a large percentage of people, or it can be associated with some pulmonary conditions. So anything that puts stress on the right heart can give you right bundle branch block. So your pulmonary stenosis, pulmonary hypertension, pulmonary embolism, but also obviously MIs and then fibrosis. Your left bundle branch block is usually caused by left ventricular disease. So aortic stenosis, hypertension MIs or other kind of severe coronary disease. And then can I have the next question? Okie dokes. Probably, I don't know if I'll get to the last one, I'll probably finish after this one, maybe, we'll see. So a 36-year-old man presents with the sensation of a racing heart. His blood pressure is 110/70, respirate 14, O2 sats are normal. ECG shows a narrow QRS complex tachycardia with a rate of 180. You diagnose a paroxysmal atrial tachycardia. You do carotid massage and Valsalva, which do not help. What do you do next? All right, looks good. Can I have the next slide, Ross? Perfect. Okay, so most of you were absolutely correct. So what you do here is give the patient adenosine. Usually, I don't know if you know that, you try and give it to as proximal an artery as you can. So usually if you've got someone with a cannula in, let's say, the hand or the wrist, that wouldn't work. You have to have a cannula at least in the ACF, if possible, higher up. That's because the half-life of adenosine is like half a minute or a minute or something like this. So it's very, very short, and you want it to get, or second, so you need to get it to the heart as quickly as possible. Can I get the next slide? So we're going to talk about tachycardias real quickly and how to diagnose tachycardia that you're dealing with. So just instead of learning what the sign and the ECG changes and the symptoms for each one of them are, it's just quite nice to learn the ways to kind of narrowing down your options. So the first thing, we're talking about tachycardia with a pulse, because Ross has talked about BAs and asystoles a little bit earlier. But generally what we look at first is your QRS duration. So you look at your QRSs. If you've got a narrow complex QRS, we think it's generally coming up from your atria, but obviously there are some rare occurrences where it can come from the ventricles. And then if you've got a wide complex, you're more thinking of your ventricular cause, but obviously there are some exceptions as well, as always. What you then look at is the regularity. So if you've got a narrow complex tachycardia that's irregular, most often it's going to be your atrial fibrillation, and it can be also your atrial flutter. If you've got something that's regular, you think of a SVT, so supraventricular tachycardia. That basically means tachycardia originating from the atria. That's a regular tachycardia. So that's your sinus tachycardia, your atrial premature beats, could be an atrial flutter as well, and then several other different types. And then if you go into wide complex, you start thinking of your VT, VF. It's also important that you have some aberrancy versions, which can look at can be wide complex, but the original. Can I have the next slide? Some of ECGs, just so that we're clear as to what we're talking about. The first one, I think we can all appreciate atrial fibrillation. So we've got the uncoordinated atrial electrical activation. So the irregular heart rate. So you've got the R intervals are not in distances from each other. And we can't also see CSP waves do not originate generally from the SAN. They originate throughout kind of the atria. It's something that you're going to encounter very often on the wards and appears very often in questions. And thus, there's a lot of risk factors. Generally, anything that distends your heart can cause AF, because like I said before, distension impairs the circuitry in the heart. So age causes obviously some distension. Hypertension also contributes to AF. Valve disease, heart failure, all the lung diseases, but also substance abuse, so caffeine, drugs, and then hypothyroidism is something that commonly comes up in question as well. Right. I don't think I'll go through every single bit because there's quite a lot of information. So can we have the next ECG? All right, so here we see ECG that looks a bit different. So going back to the diagram, it's a narrow complex tachycardia. If we were to plot the RR intervals, they look fairly regular. But what we can see is that sawtooth kind of a baseline. So we don't have that nice flat baseline between your between the signals. So that makes things of
Sorry, everyone. We'll just give Yed a second because he keeps phasing in and out, but hopefully he comes back.
Can you hear me, Ross?
Yeah. You're back now.
Oh yeah, sorry. Can I have the next one? I don't know where I disconnected. Sorry. All right. So this ECG, same as last time. So first thing we look at is whether it's a narrow or wide. We can obviously see that's a narrow, complex tachycardia. Then we look whether it's regular or irregular. And then we can see that it is generally very much regular. There's two large squares between each QRS. Can we see the P waves? We can't really see the P waves, which straight away brings us to the conclusion that it's most likely just supraventricular tachycardia. Those P waves do exist, but the distance between the and the QRS is so small that they get basically buried. So this is what's happening with our patient right now. And generally the treatment what you start with is your Valsalva maneuvers or your carotid massage. Why you do it? Because both those maneuvers increase your blood pressure up briefly. As your blood pressure goes up, the amount of blood your heart pumps will go down. Less blood is coming back to your heart, causing your heart rate to speed up. And at that point, once it speeds up even higher, your heart kind of resynchronizes, hopefully. The medical option is to go for the adenosine, which has kind of the opposite effect. If you ever give someone adenosine, it's quite a scary thing to do because when you look at them, it's associated with in textbooks and questions that sense of impending doom. And they're going to be sitting over there with the eyes open, kind of talking to you, feeling like something's going to go wrong. And then they're going to go into a second or two of complete like asystole, and then the heart's kind of just going to reset. But it generally works very well. If it doesn't work, you can try your beta blockers and calcium channel blockers. If that doesn't work, you can cardiovert them usually. Can I have the next ECG? This one is a bit more tricky because it's a bit difficult to tell what it is, but that's basically your Wolff-Parkinson White. So that is similar kind of question as the cardiomyopathy question. But in this time, you've got, let's say, your 30, 40-year-old gentleman who has done something, exercised a little bit, but then you do the ECG and you see this tachyarrhythmia and you notice the delta waves. which are the quicker kind of upstrokes at the beginning of your QRS. That is because you've got an accessory pathway. It's called the bundle of Kent. So instead of the heart signal from your atria, instead of going through AVN and then being slowed down at the AVN, because the AVN is really good at slowing the signal down so that your left atrium can be depolarized as well before the ventricles. That signal goes through the bundle of Kent, skipping the AVN, goes directly to the ventricles. So your QRS kind of starts a little bit faster, which is where you get that delta wave. Regarding the treatment, if it's symptomatic, you can also put them on some antiarrhythmics. All of the ones that we talked earlier kind of apply. But the best treatment is ablation. So you can easily map where you've got that bundle of Kent, and using kind of cold or heat or radio frequencies, you can ablate it to completely basically eliminate it. Can I have the next one, please? So this, hopefully we know. So first of all, it's a white complex tachycardia. Generally it looks regular, which makes us think it's a VT. Sorry, yeah, broad complex, yeah, it's a VT. And then there's a few kind of common signs when it comes to VT. So generally in a VT, you've got your P waves and QRSs occurring at different rates. You can have something that's called capture beats. That occurs when your sinoatrial node transiently captures the ventricles, meaning you've got a normal QRS at some point. And then you can have your fusion beats as well, which is when your sinus and ventricular beats coincide to produce what's called a hybrid complex. The next thing that we talk about is concordance. So generally in a monomorphic VT, you've got your uniform QRS complexes within each lead, like in this one, but you also can have polymorphic VT, which is when QRS changes amplitude and axis, which I have on the next slide. Can I have it, Ross? This is your polymorphic VT, also known in this example as TORSAD. And the treatment would be if someone is hemodynamically unstable, but there is a pulse, you can cardiovert them, or you can start them on amiodarone infusion. If someone is pulseless, you would start your CPR and do what Ross told you to do earlier. And then the last one, can I have the slide? That is basically your what looks kind of like chaos. That's your VF. That's your bit of panic. That's your chaotic, irregular deflection. So your QRSs of very varying amplitudes. Your amplitude will eventually decrease with duration. You have no identifiable P waves, not really identifiable kind of perfect complex QRS complexes or T waves. You need to start your ACLS as soon as possible, because otherwise you don't really have patients reverting back to normal rhythm from VF. And then the next one. And just quickly through the answer, it shouldn't take us more than 2-3 minutes. So we've got a 45-year-old female patient on the ward. A review of the patient's medical record shows that her systolic blood pressure was greater than 140 at both her last clinic appointments. Her medical history is significant only for diabetes. Her blood pressure is 164/90. What's the best step in her blood pressure management? All right, just so we don't go over by too much, can I have the next one? So the correct answer here is C. So you start an ACE inhibitor. So this is someone who's got hypertension, who's also diabetic, which is important in the question of this context, and who's under 55 years old. Generally, what we do with patients who are who come in and have high blood pressure, all you need at the beginning is repeated measurements. So as you're going to encounter on the wards, if you've got patients coming in, the blood pressure, they don't like hospitals, they are a bit scared of why you need to see them. So often I've had patients in my preoperative clinics whose blood pressure was in the 180s, 190s. But if they do it at home, they send you the readings and it's like 120 or 130. It's absolutely fine. So you need some repeated measurements. So you want them to do it at home, or you just ask them for several measurements whilst they come to your clinic or at their GPs. And then if they're persistently elevated, then you start with management options. Can I have the next slide? So first, with all the managements, you've got your three options. There is your conservative, there's your medical, and then you've got medical options. I think if you've got your medical options, conservative options, you've got several possibilities. The most effective is asking them to lose weight if they're overweight. You've got your dietary changes that are also very effective. And then you can do some things that are less effective. So try and eat less salt, increase the physical activity, and decrease your alcohol consumption. But in most cases, we go to medical treatment. So can I have the last slide? I think that's my last.
You're still there. We can hear you. Yeah, we can hear you. Sorry, people. We'll be finishing up. He's disconnected. He might be able to rejoin. If not, this is the last slide anyway, so we can just briefly talk through it. So yeah, this is just our treatment of hypertension. So again, just following the algorithm. So yeah, if they're less than 55, we're starting them on an ACE inhibitor, or if they're diabetic. Otherwise, if they're over 55 and he's back. There he is. Oh. Anyway, I'll keep going through it. Otherwise, we put them on a calcium channel blocker. And yeah, we just need to follow. I think the most, for exam purposes, where they'll catch you out the most is where they'll give you a potassium level, and they'll be at stage 4. And they'll be asking you what to add in. So it all depends if their potassium's over and above 4.5. So if it's less than 4.5, then you consider starting something like spironolactone. Or if it's over 4.5, then you would think about starting something like a calcium blocker or a beta blocker, because that's not going to impact your potassium level. Spironolactone is potassium wasting. So you don't want to be lowering it if it's low enough as it is. Otherwise, you can see on the right-hand column when or what sort of BP targets you would aim for. I'm not going to go into too much detail because we've run over quite a bit. So otherwise, we will finish the session there. So thank you very much. I apologize. I realize we went quite a bit over time. Thank you very much for those of you who stuck around towards the very end. I appreciate it. Me and Yed would be immensely thankful if you could fill out the feedback links. I remember when I was asked to do that and I never really seemed to give a toss back then, but now you actually realize for our portfolios and stuff, it is immensely helpful. So I would really appreciate that. If you've got any questions, I'm happy to hang around for a few wee minutes. and happy to answer them in the chat or if you want to come on the mic. Otherwise, yeah, we will end there.
Oops, sorry, I think I really disconnected again.
Yeah. Sorry, we're just finishing up. Don't worry, I went through the last slide.
Oh, amazing! You're the best. Thank you so much.
No,
thanks, everyone. I hope it was at least remotely useful, and good luck with everything.
Yeah, good luck with your exams, guys. You'll smash it. I'm just saying, yeah, if anyone wants to answer questions, we're happy to hang around for a couple of minutes. Where will recordings be uploaded? I think Harry said that earlier on. I'm not too familiar. I imagine if you signed on with an email, you'll be sent a link afterwards. I think it might actually be if you fill in the feedback as well. I can't remember. Sometimes it's like that. They'll be sent to you via an email, most likely. Yeah, they'll share you. Yeah, so that's what Harry says. They'll share it with you. So if you've signed into this session, yeah, don't worry. The recordings will be with you in a bit. Right. Otherwise, I'm not seeing anything in the chat. I'm going to end it there. See you later. Have a good night, everyone.
Thanks so much. See ya.
See you. Bye.